Welcome to 5-Minute Journal Club, the current and future role of tumor-informed ctDNA assays across oncology. Today, the first of a two-part series on urothelial bladder cancer with Professor Thomas Powles from the Barts Cancer Institute, Queen Mary University of London, in London, United Kingdom. This is medical oncologist Dr. Neil Love, and to begin this review of key presentations and publications, I asked Professor Powles to comment on his work in the adjuvant setting, particularly the IMvigor011 study evaluating the PD-L1 antibody atezolizumab utilizing the tumor-informed ctDNA Signatera assay.
Thank you, Neil. Firstly, the trial I'm going to talk about now is called IMvigor11. It's actually the daughter of a trial called IMvigor10, but the names aren't that helpful, but the principle is very simple. Essentially, we have a new technique called circulating tumor DNA, which many of you will actually be using already. And it's essentially a blood test. And in that blood test, we can identify DNA specific from the tumor in urothelial cancer. The way we do it is using an informed approach, using the Signatera assay, where essentially we identify mutations from the primary tumor by doing whole exome sequencing on the primary tumor, and then we track those, or we identify them in the blood. It takes a little while to get the first result back because you've got to sequence the tumor. But after that, you can do serial testing, and it's much quicker because you're actually tracking the same mutations. This is probably the most accurate technique. There are other techniques, but they're panel-based. They're not informed approaches, and there's quite a lot of noise in those techniques potentially. And what we've done in urothelial cancer in the adjuvant setting, so that's after a apparently successful operation in those individuals who've had a CT scan post-operatively and essentially have been told they've had a successful operation and given the all clear, we know in half the patients those cancers come back. And what we did in IMvigor010, the first trial, is we employed this blood test and we identified that half the patients are ctDNA positive. And if you're ctDNA positive, you've got about a 95% chance of the cancer coming back. And if you're ctDNA negative, you only have a 25% chance of the cancer coming back. Now, why is this relevant? It's relevant because at the moment, we're giving adjuvant immune therapy to unselected patients. But in all the trials we've done with pembrolizumab, nivolumab, and atezolizumab, we've never achieved an overall survival signal for unselected patients. And that's for two reasons. Number one, immune therapy doesn't help everyone. But number two is half the patients, the cancer's not coming back. And so we're over-treating half the patients completely, and then the immune therapy is probably only working in a quarter of those who need it. And that's why overall the results are unspectacular. But in the retrospective study, we showed that if you focus on those patients who are ctDNA positive, you then get an overall survival benefit, and in the negative patients, no benefit was obtained. So quite simple, but the problem is it's retrospective. And so what we did is we said, let's do this prospectively. We essentially repeated the experiment, but this time prospectively. It involved a lot of patients because we had to screen about 1,000 patients, as you can imagine. And we did two things. The first thing is if you were positive directly after the operation, you received atezolizumab or placebo. If you were negative after the operation, we tracked those patients. And if they became positive, they also got atezolizumab and placebo. And those patients who were negative, who remained negative, had surveillance alone. In the patients who were positive or negative and became positive, all those patients essentially relapsed, as they did in IMvigor010, and atezolizumab was associated with a 40% reduction in the risk of death, and that is the first time we've achieved significant overall survival in this setting. In those negative patients who remain negative, actually only about 5% of those patients at 2 years die of urothelial cancer. Those patients are at much lower risk. Now, don't get me wrong. When we look at this from the back of the room, there are two observations. The first is we're over-treating patients using an unselected approach. Using this approach, we can identify those patients at higher risk who are more likely to benefit. And by sparing those patients at much lower risk, those patients are no longer being exposed to that 15 to 20% chance of life-changing toxicity and only a small death rate associated with bladder cancer. Now, the test is not perfect. The test, of course, there are some patients who are negative who still relapse, but you can give those patients EV pembro, and it's only the minority of those patients you can give them EV pembro when they relapse. And of course, in the positive patients, atezolizumab is not curing all patients. You'll see by the shape of the Kaplan-Meier curve that the effect of immune checkpoint inhibition in urothelial cancer overall is relatively modest. It's not curing everyone. So there's still work to be done here. But this is the first time in urothelial cancer that we're pursuing this personalized approach by identifying those patients at risk and then achieving an overall survival benefit.
So a couple of questions. One, you're in GU oncology. How would you conceptually compare the use of ctDNA and urothelial bladder cancer to what we are doing now with PSA relapse, a la Embark, short-term endocrine therapy?
PSA has been with us for a long time, and PSA is quite specific. It's a useful test. Now, don't get me wrong, at lower levels, there's a lot of noise. I'm sure you're aware of that. And there is a lot of, PSA-itis where people at those low levels preoperatively, there's some uncertainty. But it's also true that if your PSA is raised after a prostatectomy, that is almost certainly an indicator of relapse. And Neil, this is the other nice part of this, and it leads on to the talk we gave at ASCO GU just a few weeks ago. You also get different levels of PSA. And so you can have 0.01 and that representation of lower risk. But if you've got a 5 or a 500 level, that's clearly a big problem. The same applies with ctDNA. The parallels between PSA and ctDNA are actually very apparent. I have described to you positivity and negativity by ctDNA, but that is an oversimplification. And I'm going to explain to you why that's the case right now. So to define positivity, you need to track or have 2 or more clones that you can identify that are aligned with the primary tumor. So one clone and you're negative. You could have one clone and have very high levels because you can have different levels of ctDNA for each of these clones. We call it an MTM level or a variant allele frequency level. And you can go from 0.01 all the way up to sort of 30. You get very high levels. And essentially what we've shown is not just positivity and negativity are associated with outcome, but the degree of your ctDNA level also correlates with outcome. So if you relapse with very high ctDNA levels, your outcome is less good than if you relapse with lower levels. And what this means is in the future, we can be tracking patients with time. It's not just, are they positive, are they negative? You can say, okay, like the PSA, it's 0.01. That's a marginal level at this point. Let's do another test in 6 weeks' time. It goes up from 0.01 to 1.2. That's a big jump. And then you'd say, we now need to jump in. And it's possible at those levels, you're still radiologically negative. You still do not have radiological relapse. And so what essentially I'm saying is, while in IMvigor11, we have demonstrated in a very clear experiment, very precise, that it is prognostic and predictive in this particular setting, in the adjuvant setting in bladder cancer, we've gone on to show that actually it is also a dynamic test that can give you very useful prognostic information. And that does not only apply in the adjuvant setting in bladder cancer, it applies tracking with time. And of course, we've done a whole load of neoadjuvant work as well. And some of the neoadjuvant work, which we can talk about in a second, that prognostic information and that ctDNA level will give clinicians an idea in the future of how much a particular patient is at risk.
Yeah, that was my last question about this, which is obviously we're going to see, we are seeing a shift already in the use of neoadjuvant EV Pembro. I don't know if there are adjuvant trials of EV Pembro that are ongoing, but if you have a patient, do you think this same model really in patients who don't get neoadjuvant, we'll talk about neoadjuvant afterwards, but people who don't get neoadjuvant, particularly if they start out clinically high risk and they're MRD positive, would you be tempted, if you could, to use EV Pembro, or do we need data?
Neil, it's a brilliant question, because we know in metastatic disease that EV Pembro is probably curing 30% of patients. We know in the metastatic setting that single agent immune checkpoint inhibition is not achieving that goal. It would be entirely reasonable for people in the audience today to say, if you're ctDNA positive, actually you have early metastatic disease. It's just not yet visible on a CT scan. And why are we defining metastatic disease based off CT? I don't think we will in 5 years' time. I think we'll be defining metastatic or advanced disease based off ctDNA. And under those circumstances, if 95% of patients are relapsing, these patients are nearly all in harm's way. You only get one good go at treating urothelial cancer. Why not give the best drugs first? Why use a single agent immune therapy and maybe chew up your best regime of EV Pembro and make it less effective in the future? And that, Neil, is a brilliant question. There are two schools of thought to that. They're the realists and they're the pragmatists. The realists, the precision people, say, let's only do things that we know. And what we know at the moment is single agent immune therapy works here. And actually, it's less toxic than EV Pembro, and we're curing some patients. The pragmatists will say you get one good go at bladder cancer, particularly those patients with high MTM levels. You remember I said that you can have different levels of ctDNA. Let's say you come in with a really high ctDNA level. You might come in and say, look, this patient's in harm's way. Let's give the best drugs we can. And the pragmatists in the audience might say, metastatic disease is only a few months away. Let's give the best drugs we can now. And I would be the purist in me feels, the hairs on the back of my back sort of getting anxious about that. But the pragmatist with the patient in front of me thinks that's probably the best treatment for them in the future. If you did put EV Pembro there, it would definitely work. But Neil, can I put one caveat? Because I think the question you've asked actually has a level which we do need to discuss. Is ctDNA clearance with immune therapy drugs is different from ctDNA clearance with chemotherapy, with targeted therapy, and with ADCs? We know from a study in Keynote 361, which was a study where we compared chemotherapy with pembrolizumab, we could see chemotherapy was associated with actually a 40% clearance rate in advanced disease. But that didn't correlate well with outcome, where immune therapy was only associated with 11% ctDNA clearance. But those patients that cleared with immune therapy, they had brilliant outcomes. So I think EV Pembro would have a much, much higher clearance rate. I think it'd be 90%. I think it will be durable because of the nature of EV Pembro. But I think ctDNA analysis is not just dependent on the time of the analysis and what treatment patients have had before, but also the treatment that they receive. And ctDNA clearance with immune therapy, and both Rela and nivolumab in these trials are immune therapies, so I expect them to have a similar mechanism. They will have more durable outcomes than chemotherapy. We've got no data for EV Pembro at the moment, so we genuinely don't know.
And of course, involving the patient in the decision, if they want to be involved, also can be helpful in these difficult decisions. One more question. Anything you want to add to what you said about this, based on what you presented at ASCO GU, looking at the dynamics of ctDNA? Anything there that came out you want to bring up?
Yeah, so I think this was a I think this was an important presentation because it introduced the concept of different levels of ctDNA, which is new, and it also introduced the concept of those levels, those dynamic levels changing with time. It's a detailed presentation, and the slides in the presentation, which you can get access to, give a lot of information. In essentially, though, it boils down to two quite straightforward facts. Number one is ctDNA positivity is not black and white. Your level varies at baseline and with time, and higher levels is always bad news. Number one. The second thing is we also showed that it was not only prognostic, but atezolizumab worked irrespective of the level. And so the reason why that's relevant is if you're negative, your ctDNA is negative, the outcome is really good. If you're positive, whatever happens, almost everyone relapses. Now, the lower levels take a lot longer to relapse than the higher levels. But at the same time, you're destined to relapse. And under those circumstances, intervention works better. If you're inevitably going to relapse, having early atezolizumab still helps. And that makes total sense. And you could take that argument to a natural extreme where you'd say those patients who are negative are surveillance, those patients with lower levels, they've probably got time on their side. And maybe you could get away with single agent atezolizumab. And those patients with higher baseline levels, throw the kitchen sink at them because inevitably their cancer is going to come back quickly. And the discussant who did a brilliant job at ASCO GU, him and I chatted about this beforehand. And Jonathan was saying, and maybe we need to be adopting these stratified approaches, as you do with PSA, off baseline levels and dynamic changes.
So let's move on and talk about some data presented from the Niagara study, both at ASCO as well as GU ASCO. Can you talk about that, your work there?
Well, Niagara is a different study to the IMvigor program. The IMvigor program was an adjuvant program, and it was starting immune therapy in the adjuvant setting as a single agent. Niagara is a completely different study. It's a neoadjuvant study. And you'll be aware that neoadjuvant platinum-based chemotherapy has been a standard of care for 20 years in this environment. Niagara showed that the addition of durvalumab perioperatively, neoadjuvant and adjuvant therapy, a total of a year of durvalumab, that was associated with a 10% higher path-CR rate. It was associated with a 30% reduction in the risk of relapse and a 25% reduction in the risk of death. It's the first study in this environment, in the perioperative environment, where we showed immune checkpoint inhibition was associated with a significant overall survival advantage. And therefore, it introduced the concept that early immune checkpoint inhibition saves lives. 2 EV-Pembro trials have come along recently and show that they both also have a survival advantage. And I can park that, and we can talk about that in a second. But the durvalumab trial was different because the translational oncology program using circulating tumor DNA has been very robust. Also, more recently, we've looked at urinary tumor DNA as well. And I can talk about that in a minute. But what I'd like to start with is talking about circulating tumor DNA. In this environment, we measured circulating tumor DNA at 3 time points. We measured it at baseline for those patients with muscle-invasive bladder cancer who have not yet started chemotherapy and not yet had that cystectomy, baseline levels. We measured there. We also measured after the completion of chemotherapy prior to the surgery, and then we measured after the surgery. So 3 distinct time points. And what we showed was about 60% of patients with ctDNA before anything started at baseline. This dropped to 22%, so a big drop, high clearance rates associated with systemic therapy, neoadjuvant systemic therapy. And then a further drop from 22 to only 9% of patients post-surgery. And what that tells us is the surgery is clearing the ctDNA in half of the positive patients at that time point. And that means that ctDNA must be related not just to metastatic disease, or MRD as we call it, but also to the primary bladder tumor. And so in the neoadjuvant setting, the reason why ctDNA levels are higher at baseline is there are two sources. One source from the potential metastatic disease, MRD, but a second source coming from the primary bladder tumor. We showed if you were ctDNA positive at baseline, if you were ctDNA positive pre-surgery, or you were ctDNA positive post-surgery, it was strongly associated with a worse outcome. So it's bad news at any time point. But the hazard ratios increase with time. It gets worse and worse news if you remain ctDNA positive. So if you were positive at baseline, but clear your ctDNA, you do much, much better than if you're positive at baseline and you remain positive. And indeed, if you are positive, if you're ctDNA positive post-surgery, you've not managed to clear your ctDNA with neoadjuvant chemotherapy or with surgery, actually all of those patients relapse really, really quickly. In fact, it's a disaster. And so what we essentially showed, and that's a huge amount of work and there's lots of detail in it, but I'm going to skip a lot of that if I may. Essentially what we showed is, as was the case in IMvigor010 in the adjuvant setting, being ctDNA positive is bad news, and it's increasingly bad news because it describes treatment failure if you remain positive. Whereas if you're positive and you go to negative, those patients actually have a similar outcome to the patients who are negative all along. So we've got a new tool, and the tool is, or the new game, dare I say, use the word, I realize it's not that, but we have to clear ctDNA. And actually there is some likening to other tumor types in this environment as well, where clearing ctDNA turns out to be really relevant. If you remain ctDNA positive, even if your scan is negative, that's bad news. And we potentially need to be switching therapies based off ctDNA positivity.
Anything else you want to say about these data and what your thoughts are in terms of where it's leading in terms of new research?
So I think the ctDNA work tells us that we now have a really useful prognostic tool for patients who don't have radiologically measurable disease. I think it's helpful in the neoadjuvant setting. I think it's helpful in the adjuvant setting. I think, we are lucky at our institution, we are able to use it, and it helps me quite a lot. It is a prognostic tool predominantly, except specifically in that adjuvant setting for patients who haven't previously had immune therapy. There are two things I'd like to say which are really important. Being ctDNA positive after an operation, the IMvigor11 population, if you're ctDNA positive after surgery and you've not had prior immune therapy, IMvigor11 tells us when to start immune therapy. If you're positive, you should start immune therapy. If you're negative, you can probably get away with it. What IMvigor does not tell us is when you can stop neoadjuvant immune therapy. So for those patients who have had neoadjuvant therapy and then clear their ctDNA, potentially with immune therapy, many people say to me, well, they're negative now in the adjuvant setting. IMvigor11 tells us we can stop. That's not correct. What IMvigor11 tells us is when we can start therapy. If they've already started immune therapy and they've had 3 months and the treatment's working really well, you would want to continue that treatment, particularly the immune therapy, for the whole year. So ctDNA can tell us when to start adjuvant immune therapy, but not when to stop neoadjuvant immune therapy. That's one important fact. The second is that we've incorporated a urinary tumor DNA into the ctDNA landscape. Now, this sounds confusing, but it's actually incredibly simple. UTDNA is similar to ctDNA. You take the primary tumor, you mash it up, you sequence it, you get a series of mutations that you track. For those patients that have tumors in the bladder, it should come as no surprise that almost all patients are UTDNA positive when you measure, because the cancer is secreting loads of DNA into the urine. So that is true, number one. Number two, the technique of UTDNA is not quite as refined, and there is more false positivity. So more patients are UTDNA positive when they don't have a primary tumor in the bladder. And we need to sort out some of the accuracy of UTDNA. But what I can tell you is the following. Is if a patient is UTDNA positive, so they've got cancer cells or cancer DNA in the urine, but are ctDNA negative, that indicates they have a primary bladder problem. And if a patient is UTDNA negative, but ctDNA positive, it suggests the cancer has already spread and left. UTDNA gives us additional information beyond pathological complete response, but it's particularly relevant in those patients who have chosen not to have surgery, where you're never going to get the path-CR result. And in those circumstances, it gives you a good indicator on whether, if the patient is relapsing, is that a local relapse in the bladder, or is it a metastatic relapse? And therefore, there is a high likelihood in the future, not today, but in the future, we'll be using UTDNA and ctDNA in tandem to identify the source of the patient's cancer.
So I think these two discussions really help sort of set the stage. One thing we didn't talk about, just curious, for both of these studies, what type of specific assay was used and what assays are being looked at right now in clinical trials?
So again, this could be complicated, but it's quite straightforward. When you go back in time, we used to use panel-based approaches where we would try and just identify common mutations, and colorectal cancer and lung cancer, EGFR, P50, whatever it might be. There are two problems with that. Number one is the bladder cancer mutational landscape is quite distinct to bladder cancer, and therefore panel-based approaches don't work very well. But it's also true because of clonal hematopoiesis. There is some DNA in the blood anyway, and so mutations like P53 and other mutations can be false positives. And so therefore, while the panel-based approach is quite easy to perform, it's much quicker to get a result. And by the way, there are techniques like Guardant which are ever improving and ever becoming more accurate. It is fair to say that the sensitivity or particularly the specificity is reduced compared to the personalized approach. Everything I'm talking about today is the personalized approach, where you get the primary tumor, you look at mutations, and you track those mutations. Now, there are different types of personalized approach. I'm talking about an approach from Natera predominantly, everything I've talked about so far. But there's a Danish group, the group that looked at the Tombola trial. The Tombola trial had some parallels to InVigor11 in that it was an adjuvant bladder cancer trial which identified those patients at low risk and those patients at higher risk. That also used a personalized approach, but it was a Danish specific personalized type approach. So you potentially have different personalized technologies. I have to tell you, at the moment, the Natera approach is widely available. And so for clinicians in the US, I think that's the approach that they should be using. And I certainly would not translate these results and say that means we can use a panel-based approach or an ad hoc technique that we've decided to make up ourselves. The technology is moving quickly and it's becoming more accurate. So I'm not convinced that this is where the technology ends, but at the moment, this is the approach that we use.
This concludes part one of the program. Please tune in for Part 2. Note that the attached slide set provides more information on the papers and presentations discussed here. Special thanks to Professor Powles, and thank you for tuning in. This is Dr. Neil Love for 5-Minute Journal Club, the current and future role of tumor-informed ctDNA assays across oncology, urothelial bladder edition.